And we are live, Senator.
Okay, thank you. This is Health and Welfare, and we're continuing our work on various bills. We're now going to look at H206, an act relating to miscellaneous changes affecting the duties of the Department of Vermont Health Access. And I've also asked Ameren to draft a proposal amendment on some issues related to the bill that we can look at. And so, Ameren, this is our first opportunity to go through the bill, I think. We went through it once briefly, right? So let's go through the 10 million foot level of the bill and then look at the proposal amendment, because that piece is new, and then we'll start hearing from our witnesses.
Certainly. For the record, Ameren Abergele Legislative Council. Would you like me to screen share?
Yes,
Okay.
please.
So I am opening H206 as passed by the House. For those following along on their computers.
Andrea, you can sit there. Oh, thanks. Yeah. It's okay, and that chair is out of whack anyway.
So beginning first in section 1, this is concerning Medicaid coverage for adult dental services in Title 33, section 1992. You'll see there's some new language in subdivision 2 around Medicaid's coverage of diagnostic, restorative, and endodontic procedures, which currently has a maximum cap of $1,000 per calendar year. There was the addition of allowing the department by rule, Department of Vermont Health Access, that is.
So it raises the dental cap.
The dental cap remains at $1,000 in this bill. Then there is codifying some exceptions to the annual cap, which you'll see on page 2. First, individuals served through the Community Rehabilitation and Treatment and Developmental Disability Services programs, and then Medicaid beneficiaries who are pregnant or in the postpartum eligibility period. So that is section 1 about dental services. The second section is concerning the Medicaid being the payer of last resort. And you recall this conversation, this was about the prior authorizations that a third-party insurer might have in order to cover services. And Medicaid, or the statute providing that Medicaid's, or the Department of Vermont Health Access, Agency of Human Services, the agency's authorization for saying that those services are covered by Medicaid serves as the third-party insurer's prior authorization, such that the services are covered and Medicaid can recoup from the insurer the costs for those services, as Medicaid is the payer of last resort. So that is section 2. And then section 3, switching gears once again, now we're looking at the Vermont prescription monitoring system. And this, presently the Department of Health only provides certain persons with access to query the system. And this bill would expand subdivision C on page 5 to allow that it's not just the medical director of DVHA, as it is presently in statute, but also the director's designee for purposes of Medicaid quality assurance, utilization, and federal monitoring requirements can access the Vermont prescription monitoring system. And then section 4 is a report section where the Department of Vermont Health Access must collaborate with representatives of Vermont's federally qualified health centers, FQHCs, to develop a mutually agreeable alternative payment methodology for Medicaid payments to FQHCs. And that report would be due in December of 2023. Yeah. And then the bill takes effect on July 1st, 2023.
All right. Why don't we just go briefly through the amendment proposal?
I'm pulling up draft 2.2 of the amendment for H206.
2.2?
2.2.
Oh, Alex, we have 1.2. Yeah.
It looks like you have both presently, or you should have both.
I
I have both.
We
refresh.
should have both.
Oh, yeah.
Okay, it's there if you refresh, if you didn't have it before. Okay, go ahead.
So looking at draft 2.2 dated 4/19. This would add, this would delete the effective date section and add 3 new sections to H206. The first, section 5, is a report section. Blueprint for Health, Department of Vermont Health Access report, subsection A, on or before December 1st, 2023. The Department of Vermont Health Access shall submit a report to the House and Senate Committees on Appropriations, this committee and the House Committee on Healthcare, containing a breakdown of Blueprint for Health per member per month payments to patient-centered medical homes and financial contributions for community health teams made by each payer for fiscal year 2023. The report shall include monetary totals and the number of attributed patients for each payer for each of the following types of healthcare coverage. And then we have our individual and small group health plans, fully insured large group market health plans, employer-sponsored health plans administered by the payer as a third-party administrator, Medicaid, and Medicare. And then subsection B, to the extent the department did not collect per member per month payments or financial contributions from all third-party administrators for employer-sponsored health plans for fiscal year 2023, the department shall include in its report the information required in subsection A of this section, as if the department had collected those payments and contributions, including information on how many attributed patients fall under employer-sponsored plans for each payer.
And this is just to get an understanding of how the blueprint is funded based on the payers for the services. we pay for.
The next section, repeal of prospective repeal of 18 VSA 9473G. I did ask Alex to also post an excerpt so that you can see the language that's being repealed. I don't know if you would like to go through that.
Yeah, just to bring people up to speed about what the 340B involves, and I know that we'll probably get testimony about that going forward, but why don't you bring that up? And I will accept responsibility for being the bad person. That's good stuff, just kidding. Shouldn't say that.
So now we're looking at an excerpt from Title 18, Section 9473. This is concerning pharmacy benefit managers, required practices with respect to pharmacies. So I included some of the previous subsections so you can see the types of information that's in this section for a little bit of context.
If I can just ask a question. It looks like a repeal of a repeal.
It is a repeal of a repeal.
Can you, okay, so,
I can.
You got it.
So I'm going to scroll down to the second page. You'll see the previous subsections if you wish to look at them. It's a lot of requirements about what a pharmacy benefit manager or other entity paying pharmacy claims must do, participation contracts between PBMs and pharmacists, the payment of claims, more contract provisions, terminating contract. So the section that we're looking at keeping in statute is subsection G, which says a pharmacy benefit manager shall not, 1, require a claim for a drug to include a modifier or supplemental transmission or both to indicate that the drug is a 340B drug unless the claim is for payment directly or indirectly by Medicaid, or 2, restrict access to a pharmacy network or adjust reimbursement rates based on a pharmacy's participation in a 340B contract pharmacy arrangement. So this section was put into statute. There was a built-in repeal in session law in the budget. I forget which year, but it's on
2025, I think. Is it?
so there was the original setting for the repeal date for this section. The repeal date was then extended, I believe, in 2022, so that
24.
now it will be repealed effective April 1st, 2024, unless you repeal the repeal, in which case this will remain in statute.
So, without having this repeal, the lower drug costs that are available through specified pharmacies, providers, those lower drug costs will not be automatically available. Rather, the PBMs will have opportunities to raise prices. So what this does is it maintains the lower cost drugs, especially for those who are lower income or economic or in greater need. So we'll continue to provide the lower cost drugs at those pharmacies. So that's the kind of testimony that we'll be hearing from folks on this section.
And the repeal of the repeal in 2024 is permanent? Or does it have a date on it?
No, it's a repeal, it's gone. And then, what will happen is that the 340B, that's what they're called, pharmacies, will continue to be able to sell these or purchase the drugs at a lower cost and then provide a lower cost prescription for patients.
In perpetuity?
Just to make it, I'm trying to simplify it without being long.
Gotcha.
I've done it.
Why not do it for everybody?
Well, we'll hear that testimony. That's a very good question as who can access the 340B pharmacies and how that all happens.
To achieve the lower drug price, who pays? Or is it,
The
is it simply the
pharmaceutical
pharmacy?
industry.
Okay.
Yeah.
They're just being somehow incentivized
Mhm.
to, okay. It's not okay.
The
great.
question, this is under the bigger frame of the cost of prescription drugs generally and how drug prices are not regulated. So what happens is, especially in our country, we pay higher drug prices than perhaps you pay in Canada or another country, and we don't have access to those lower costs, except through some programs such as the 340B program, which was federally established, and I think Mary Kate Norman would be able to talk about that a little bit. And so what it does allow for is for the lower purchase of prescription drugs and then the lower cost to the patient ultimately. So overall, it's a savings. And so the sunset would, once it's repealed, would allow for that lower cost access to continue. Mistake, did I make the one? No. Okay. Questions for Amarin. So this is those two sections on blueprint to look at how our community health teams reimbursement takes place or payment takes place. And then the 340B is added in would be added in should we decide to do that after we've heard testimony. Okay. Good, thank you. So we'll hear from folks who are here, and I think Commissioner Akiva is up first. You want to keep the bill up on, you have testimony for us, I think, right? Not yet? Okay, all right. Good. That's okay. It's your bill, I think.
It's our technical bill.
Yes. And do you and Ginger want to be together up here?
Yes.
Okay, good.
Okay, thank you. Okay.
Good. Thank you for being here.
Thank you for having us.
All right. Why don't you go ahead and introduce yourselves for the record, and then you've heard some of the questions starting out on the bill itself, and then we'll go ahead.
Sure thing. Well, thank you for having us today. For the record, Andrew Delevrier, Commissioner for the Department of Vermont Health Access. Joining me today is Ginger Irish, Director of Communications and Legislative Affairs at DEPA. I'm happy to be here. Are there specific questions you have for us regarding H206, which is the technical bill?
Not really. I think on the amendment we may, from your perspective, but if you could just give us some supporting information about the bill as it is. It seems to be without controversy, and I think it's important for us to understand the sort of the reasoning behind the sections of the bill and what you're bringing us.
Sure. Do you want to start?
Yeah, certainly. I'm happy to just walk through the bill section by section and take questions as they come, or if you prefer to wait to the end, certainly what you prefer, Madam Chair. So section 1 is about Medicaid coverage for adult dental services. Through the Global Commitment for Health waiver, we were able to negotiate removing the dental cap for certain vulnerable populations. Those are Vermonters served by the Developmental Disabilities Service waiver and also the Community Rehabilitation Mental Health and Treatment waiver. So the proposal includes waiving the cap for those individuals and then also waiving the cap for emergency dental services. And I believe, are there any questions about that?
So it was a negotiated agreement that you have made within the global commitment to do this. And so you've removed the cap completely for those specific patients.
Yes.
I'd like to, if I could also add just a clarifying point, that this is separate and apart from the governor's recommended dental rate increases and increases the cap. So this is the separate track.
Right, and that is down in appropriations. We've been talking about it there. And then if we're raising the reimbursement, we can also, I suppose it's down there, we discussed about raising the cap or changing the cap. But it's something we might want to discuss in here. Did you think about that as you were looking at the governor's recommend reimbursement?
For the dental rate increases?
Yes.
In the big bill?
Yeah.
So it was contemplated in our estimate to accommodate for a $1,500 cap, which is currently 1,000. So it is contemplated in
So it
that.
could
but we
go
didn't
up
specifically
to-
ask for it. Correct.
Well, this committee might have that discussion and make a recommendation down.
Sure,
But we're gonna have to do it quick. We're passing the
sure,
budget out.
definitely. Go ahead.
So just for clarity, the governor's proposal was to raise it to 1,500.
The governor's proposal was to raise it to 75% of Northeast Delta dental rates.
Okay,
In discussions that we had internally, we identified that it was not necessarily requested to increase the cap at the time. That came afterward. But when we went back into the analysis, we found that we had already accommodated for the $1,500 increase, and which is why we had proposed that as a solution to house healthcare.
Okay,
thanks.
thank you. Any other questions about that? Okay, well, good.
Okay, great. So section 2 is about third-party liability. The federal consolidated appropriations.
Yeah, sorry, I didn't know you were
Oh, yeah.
moving all the way. So back to section 1. Do you have rough numbers on the populations that are in this section B?
Yeah, for the community mental health rehabilitation and treatment and the developmental disabilities groups that are served under the waiver, the estimate is 5,500 total Vermonters. These are vulnerable Vermonters that often require more expensive treatment and at times sedation dentistry, which is why it's important to remove the cap so they're able to access services.
Okay, and then the Medicaid beneficiaries who are pregnant or in postpartum eligibility, rough number for whatever you use for estimate purposes.
It's a great question. That change was actually made in 2012, but the statute was not updated. So we chose to include it here to ensure we reflected that change had occurred.
Thank you.
Will you get us your testimony so we can put it on? I'm trying to memorize.
Yeah, me too.
Okay.
Section 2 is about third-party liability. So the Consolidated Appropriations Act of 2022 made a change to the Medicaid Act, which essentially says that if a patient is covered by Medicaid and a private insurance, but at that time, Medicaid is not aware that they have private insurance. Medicaid is billed and pays for that service. Private insurance can't then deny Medicaid's attempt to recoup because they would have required a different authorization for that service under their insurance. It essentially says if the service is covered under the Medicaid state plan, that those insurers must pay Medicaid back for those services because Medicaid is always the payer of last resort. So it's a federal change, so that's why it's in our DIVA's technical bill, because we are required to align with that change.
Questions on that section? Okay.
Section 3,
Which is on page 4.
yes, Vermont prescription monitoring system. So this is a system that Medicaid uses to be able to look across all the pharmacies in the state and check whether a patient is getting prescriptions at different pharmacies. The issue at hand is that currently our medical director is the only individual who has access to that system. So if the medical director is unavailable or the position is vacant, no one at DIVA is able to access to look at these pharmacy records. So the request, and we've worked with stakeholders to come into agreement about this, is to allow for one designee of that position to also manage that system.
Does that make your life easier?
I think it's improves patient safety.
It is.
So yes, in the
Okay.
end.
Greater access.
Yeah.
Okay, good. Thank you.
So
Sorry,
section 4, would you like to take that? Would you go ahead and see?
I can't see it.
Certainly. Oh, this is the alternative payment methodology report with that.
Oh, right. So section 4, federally qualified health center alternative payment methodology report. This draft is language that we had worked with by state and their representative members on. So we are comfortable as it stands, although I do know there may be other considerations in your email or on your desk. So I'd like to talk a little bit about those if we have a chance.
We have, I don't, but would it be coming from FQHCs? Okay, so we'll hear that, and if you're in the room, then we can get into a discussion.
Sure thing.
Do you have any comments to make on the amendment that has been proposed, the 340B and the blueprint?
So 340B, we are pretty neutral on. We don't have any comments as it stands. Most of you have heard something different. The blueprint report is, did you hear back from Cheryl? Okay, so that is a piece where I'm not sure where that landed because Shayla had spoken directly.
Well, and I saw her in the building, maybe I'll put her out for a little bit later.
That would be great.
Yeah.
Because a lot of the central office intersects with that
I
program.
know.
And I don't have the most up-to-date information, but I do know that we would have a hard time reporting on other payers. That piece
Well, you can't do that. Yeah.
I'll let Shayla handle that if that's okay.
All right, well, we'll stay posted on
Okay,
that. Thank you.
thank you.
Questions committee for Diva.
Yeah, I do. Going back to section 1 in the base bill. So just trying to read through page 1, starting about line 10 and down. So the folks who are in category B, which is line 19, the following shall not be subject to the annual maximum benefit. Is this, again, just trying to understand the language. The groups that are highlighted under B, this is not just for emergency services, this is for all services. The cap is removed completely. Why, what's the logic for completely removing the cap for those subgroups?
That's a good question. We can start and then hand off. So it was an opportunity provided by the Global Commitment Waiver. And this is a population of individuals who have a difficult time accessing treatment and are also sometimes more difficult to treat. And it doesn't take long to hit the $1,000 cap. And what we found was that those individuals perhaps would not be able to get services beyond that if they were capped. Really necessary services. So that's the consideration. And so it involves not just the Department of Vermont Health Access, but also the Department of Mental Health and the Department of Disabilities, Aging and Independent Living. So it is actually a partnership with them and their programs to transfer money between the departments to allow for this access to happen. Do you have anything to add?
Just that those individuals who are served through the Developmental Disabilities Services Group, Community Mental Health Rehabilitation and Treatment are often people who have severe mental health and issues, disabilities, and often can't just go to the regular dentist. So those services are more expensive, especially if they're requiring sedation or requiring a different setting to receive those services in a safe way.
Good.
So, yes.
And they're not currently covered under any other program that provides a benefit, whether it be Medicaid or otherwise. I don't know.
No, that's a good question.
So currently DMH and Dale both have some funding available on an as needed basis through a voucher program that folks can apply to get some of that money. So through this negotiation, we were able to ask those departments to transfer those funds into DIVA so that it can just be part of the Medicaid benefit in the state plan through the global commitment waiver. So rather than having those individual applications to those funds, we're simply waiving the cap for those high-risk individuals.
So it simplifies administration and it adds increased support for some of our most vulnerable folks. Yeah.
Okay, so I understand developmental disability services who might be potentially covered under that, but community rehabilitation and treatment, it's a completely different group. Is that more like drug rehabilitation, post incarceration?
Do you have the definition of that?
It's for mental health treatment specifically,
In the
for folks who have,
Okay.
yeah, mental and behavioral health treatment.
Okay, thank you. Thank you both.
And if you can get your testimony to us, that'd be very helpful. We've got good data in there. Okay. Thank you.
Thank you very much, Madam.
All right. So we'll move on to, we have Mike Fisher and Mary Kate Molman. Either order is fine. Yes. Mike, one. And if there are others who want to testify, just let Alex know. I know.
Good morning. Mike Fisher, healthcare advocate. I sort of thought when I was on my way in here today that I would have pretty much nothing to say other than support the bill. But I think hearing this conversation, I think it makes sense for me to say a little bit more about the healthcare advocates' role in some of this stuff and our perspective. In the House, our advocacy on this bill was really just about Section 1. Access to dental is one of the bigger crises that Vermonters are dealing with around access to care. And as you know, we run a helpline and people call us every day with all kinds of issues, many of which we can really help them with. But the really, really tough ones are, I'm in pain and I can't find a dentist to give me care. Over the years, we've partnered with the free reduced, the dental clinics, the QHCs have provided, a key part of the infrastructure, but there are parts of the state where there just aren't dentists available. And so we very much support the administration's proposal in the budget to raise the dental rate. And we very much support the provisions of this bill to eliminate the cap for certain subpopulations. That makes a lot of sense to us. I'll just remind you, not only it's true that the postpartum group has been in place for many years, but there's a recent change in definition of postpartum from 60 days to a full year.
To a full year.
And so that is very important improvements in access. Those are good things. We came to the House Healthcare Committee in the context of the budget to say, we support the increase in the dental reimbursement rate, but that it represented a loss of buying power for people under the cap, who were still subject to the cap. And the HCA's position has been and continues to be that we should eliminate the cap. That people who are in need of care, telling them they can't get that care until a calendar year passes does little that other than allow for their conditions to get worse, bad outcomes for them, and more expensive care. And so we appreciate that the administration came back and said we can raise it from 1,000 to 1,500. That keeps pace, keeps those people who were up against the cap level, maintaining their buying power. But I will add that we were told that in 21, I think it was 2.9, close to 3% of people on Medicaid reached the cap. So 3%, just under 3%. Even though it is a small group of people, the cap is still painful. Really planned that for a set of Vermonters who need care. And so we continue to advocate for improved access. I apologize, I know, well, I guess I do have a alleged counsel question. Should that $1,000 cap that is being contemplated in the budget, House budget raises it to 15, be reflected in this bill is an overall question. And I know that there is conversation down the hall in the Senate about raising it further. Additionally, on dental, we did advocate for a report back in the context of the 26 budget from DVA. What would it take to eliminate the cap? What would it cost to eliminate the cap? I'm sorry that I have to propose, we proposed it for 26. I'm sorry it's so far out. I couldn't think, they need a full year before being able to do that. The conversation in Senate appropriations has been to not include that study language. And I'll just say, it's true that senators can ask for numbers from the department at any time with or without study language. The study language seems really important to me as the advocate because it puts it back in front of us directly.
Maybe take like 3 more minutes. And then,
So
yeah.
those are my comments about dental. It's very important. Continue to advocate for more. I want to, about the amendment, proposed amendment, there was also in the budget, a section, I believe, coming out of the House about blueprint funding.
Yeah, there is, and we'll deal with that in
And
appropriation.
so I just wanted to
Yeah, no.
remind
Yeah,
us
because
that-
I've been working on that down there. It may be slightly different, and just all we really want to know is your support for and moving forward in this direction or
Yeah.
not. And then, because I'm gonna have to
I'll just-
harder and talk with Shayla and others on this going forward.
I'll just make a high level comment. It has always seemed problematic to us that Blueprint was for all Vermonters and was not being funded by all Vermonters. And so any efforts to broaden the funding for Blueprint makes sense to us. I will just add that I have always felt like the claims tax was a way to contemplate doing that and should be considered. Because self-funded plans pay into the claims. So that was a quick comment on that. And then on 340B, I think the right thing for me to say is I need to ask my team to understand it better before commenting here. I do want to say my understanding is that the way 340B works is that it provides a lower cost for the purchase of the drugs from certain entities, from 340B entities, from F2HCs, from Planned Parenthood, from hospitals, but that the payment for the drugs are unchanged. So the insurance company that's paying for the drugs or the person who's paying for the drugs don't get the benefit of the 340B price. And so the extreme example is always out there about insulin, that a 340B price for a prescription of insulin might be pennies, but that the person or the entity that's buying the drugs on their behalf, the insurance company, might be still spending $300 for that same drug. And so that difference is a revenue stream for those 340B entities, a very important revenue stream, but the benefit doesn't go so directly to the consumer, is my understanding.
We'll hear.
And
I think there's a disagreement there around the road, but we'll find out.
those entities may use those Medicaid, that revenue to do good things, but it's not a direct pass through. It's not.
Or it could be.
Or it could be. In fact, we once proposed that for insulin that Vermonters get, I think we said 3 times the 340B price as a way of saving money for Vermonters needing insulin. That was a couple of years ago. I very much like the concept that it could be passed on to low-income people with full recognition. I want to say 340B is a third rail in Vermont, well, probably nationally. It's a dangerous one to touch. I think it's important to recognize that for those entities that are getting revenue through 340B, it's very important.
Okay. Questions? All right, thank you. Perfect time.
All right.
Yes, Mary Kate, please come up. And do we have something for you on?
Yes, I shared it last
And
night.
Mike, if anything you could send us in writing, that would be helpful as always.
So I have written, would it be, and one of the things, oh, sorry, for the record, Mary Kate Molman, Director for Vermont Public Policy at Bi-State Primary Care Association. Question for the committee, would it be helpful if I put my testimony on the screen so you
Sure.
could see the amendment that I'm,
That'd be
okay. Might take a minute to set up.
I just reset you to Zoom link as well.
Thank you.
And we do have it on our webpage, so we've got it both places. And you're
It's amazing how long it's taking me to get from here.
You should be all set.
Okay, great. I will. Screen. All right. There we go. All right, thank you for your patience. Chair Lyons, member of the committee, thank you for the opportunity to testify on H206, an act relating to miscellaneous changes affecting the duties of the Department of Vermont Health Access. Bi-State Primary Care Association represents Vermont's federally qualified health centers, and we are requesting an amendment to the below provision in that bill. And I can. So this is the provision that you heard Ameren talk about. I will mention that, yes, we did talk with DEVA about this, and that had been agreed to on the House side. Our members really need to have some assurance that this is going to move forward, which is some of the impetus behind this amendment. I'm also going to say the reason is twofold. First, we want to clarify the relationship between an alternative payment methodology and a prospective payment system for FQHCs. Those are the two federally described ways to pay a federally qualified health center. The PPS we kind of think of as our federal minimum wage. It is the minimum that the state Medicaid program can pay FQHCs. And then the alternative payment methodology has to be at that prospective payment system amount or greater. And it also allows for additional flexibilities in that methodology. Getting into some technical stuff, so I'm going to try to keep it high level. Second, so yeah, the first part is we want to just clarify the relationship between those two and the amendment. And secondly, our members need assurance that this is going to go forward, that we will have an updated payment methodology by the calendar year 2023 or 2024. So we have asked that the timelines be moved up. And we also asked for the part of that timeline and reporting be a report to the Joint Fiscal Committee, because this does have impacts on budget. And we are, and we're also asking that this, that we really look forward to doing this. This process started in February of 2022. We had initially, in conversations with DEVA, aimed for a budget item in the fiscal and the Budget Adjustment Act of FY23 and FY24. That never materialized. So we want assurances that we're not going to put this off yet another year, which is why we put the language for this amendment. And so as you can see, this, unfortunately, it's split between two pages, but this first part, highlighted part, at least equal to the amount that would be paid under the prospective payment system established under the Benefits Improvement and Protections Act of 2000. That is the federal law that establishes how FQHCs are paid and how much FQHCs are paid. The second part is by October 1 that we give a presentation, or the department gives a presentation to the Joint Fiscal Committee on the progress. Again, making sure that this gets into the conversations around budgeting. And then the final report would be due to legislative committees on December 1st. So I want to pause and see if anyone has any questions about that.
Okay, so what I'm hearing you say is that you have been talking with DEVA about this, and I'm looking to see,
Not the new language, but we certainly have been talking about that.
okay. So what will this, just in plain language, what will this allow for?
This, I would say, just increases the accountability from what we had initially agreed to. It would tighten up what we are going to aim for in terms of updating the FQHC payment methodology and making sure that that gets included in the budget for ideally FY24 Budget Adjustment Act.
Okay, and then the guarantee, we're looking for a guarantee that you're not going to be receiving less than what you're currently getting.
Yeah, I mean, that's federal law. That's,
yeah.
That.
Okay. I'm looking at DEVA and not seeing.
I'm happy to comment on this time.
Okay. All right. And, okay, questions committee on this section. All right, so you're looking for an earlier date so that it can be processed by the joint fiscal committee and perhaps the health care reform oversight committee.
Yes.
And then for some inclusion or discussion within the BAA.
Yes, for any impacts this has on the budget.
Okay. Do you have any comments that you would make on the amendment? For example, on 340B?
Oh, yeah, that amendment, 340, yes, we would absolutely support that. That is, so if I can rephrase it, it's basically repealing the sunset to those restrictions on pharmacy benefit managers. The savings that FQHCs are one of the covered entities that are eligible to participate in the 340B program. We are required by federal law that the savings generated from participating in that program go back to benefit the patient population of each of those health centers. Those savings often are directly, for the drugs, are often directly passed on to the patient. The savings can also be used to help support free care for patients, such as free dental for those who don't have dental insurance. So there's a lot of ways that our members use that funding to support and increase access for their patients.
Okay, so you're supportive of taking
away the repealing that sunset language and keeping the restrictions in place.
Thank you. All right, questions, comments? I'm looking
May I?
across the room. Yes, please. We're fine to have a discussion. We have a few minutes left and we may as well get into that. And we will be picking this bill up again for others to testify or to have committee discussion. Yeah.
Great. Thanks, Madam Chair. So just to kind of recap, the language in the current H206 bill is language that we had coordinated with Bi-State on to include. We have been working with them for a long time, but most recently to identify a suitable alternative payment methodology. My understanding is there's never actually been an agreement to do that on any certain year because I don't know how the agency would ever commit to that based on the budget process. But again, that was before my time when that started, so I can't really speak to that. What I can speak to is today, as of today, we would continue to work with Bi-State. That is, we are committed to do that. We meet on a monthly or maybe even a bi-weekly basis to work toward reviewing their costs, identifying an alternative payment methodology, and realistically, the payment methodology, the payment methodology would actually be more financially beneficial to FQHCs, but we would not want to, and we want to give you a couple of options, Mary Kate, and the members, a couple of options. But it is unrealistic for us to say, yes, we commit to put this in our BAA simply because the budget process doesn't look like that. The priorities of the agency of Human Services and the governor didn't really determine where that goes ultimately and when things are implemented, but we would work very hard to identify methodologies to implement when we're given the go-ahead to do so. And we recognize that every sector is under pressure right now. So the other comment I'd like to make is just based on the dates of the report. We would propose that the final report be delivered in October versus having one report, progress report, and then in October and then one in December. I think we just do the final report in October and then end the language there. That would be my proposal rather than have two reports.
So if we had the report coming in October, then other decisions can be made relative to BAA and anything else. We don't have to demand that it happen. I know the budget process is not always clean.
Yes.
One of those fun things.
So I'm happy to talk with you. I think those are reasonable. Would you prefer for us to
Yeah.
discuss this offline and then come back?
That
with,
would be very helpful, and
negotiate.
you can connect in with Ameren on this, so we've got something that all flows together. That would be great.
Yeah, and I do want to, we have been working hard. We have been making some good progress with the DEVA team, so I don't want to frame it as they're not showing up, but our members need some accountability. And so I appreciate the opportunity and I look forward to talking with you, Commissioner.
Terrific. Okay, that'll be great. Thank you for that. Any other questions for Mary Kate or Commissioner? You're
Okay,
fine.
thank you.
Thanks. Okay, we'll close out this discussion, and if there are others who want to testify on the bill or the proposed amendment, let Alex know, and because we do want to get through the bills with our favorite word of the day, alacrity. There we are. Good, thank you. Okay, so we're gonna move on. I'm gonna suggest we're gonna move on to S79, which is not in our committee, it's in judiciary. Are you ready?
S79?
Yeah. We're going to look at S79 as a bill that judiciary worked very hard on with interested parties and came to some agreement, what my understanding is, on the bill. But the bill is very important. It isn't seen as very important by the folks in judiciary and others. And that asked us to look at the bill with the intent of amending H206 with that language. And it's not seen as an impediment to moving the bill forward once it leaves the Senate and gets to the House. So I think what we'll do, we'll look at it with that in mind, adding it on. The language is more akin to the Judiciary Committee than the Healthcare Committee. So if and when we amend it, add it on, I will phone a friend for recording purposes on the floor. So that's how that goes. So let's look at this together.
All right, I'm going to share draft 1.3 of S79, which is the Committee on Judiciary's recommended strike all language for S79 and act relating to limitations on hospital liens. As a way of background, the circumstances that the situation takes place are an individual is injured in an accident. They receive services at a hospital. They may, at a subsequent point, file a lawsuit against someone involved in the accident and then recover the monetary award to help cover the costs of medical services, lost wages, pain and suffering, whatever happened to be part of the lawsuit. So this bill would amend section 2251 in Title 18. So this is concerning the ability of a hospital in Vermont to file a lien on that monetary recovery that the patient might receive, so that the hospital can recover the cost of their services. So that's the situation that we're in when we start looking at this language. So current law says that a hospital in Vermont, as defined in section 1801 of this title, furnishing medical or other service, including charges of private duty nurses, to a patient injured by reason of an accident not covered by the Workers' Compensation Act, shall have a lien upon any recovery for damages to be received by the patient or by the patient's heirs or personal representatives in the case of the patient's death, whether by judgment or settlement or compromise after the date of services. Current language in the law says that, which you see stricken out here, the lien shall not attach to 1/3 of the recovery or $500, whichever shall be the lesser. And in addition, the lien shall be subordinate to an attorney's lien. So when the patient is recovering a monetary sum as part of this lawsuit, first part of that recovery is going to go towards attorney's fees. Then the hospital may attach a lien up to $500 of the remaining amount. So leaving the person who is injured with not less than $500 from the recovery, or 1/3 of the recovery, whichever is less. So a small portion. So this current draft would remove that $500 allowance, or small piece left for the patient, and remove that language. In addition, the lien shall be subordinate to an attorney's lien. So next I will walk through what would happen instead. So the new language in subsection B says, notwithstanding subsection A, which is the hospital's right to file a lien, a hospital shall not have a lien under this chapter if the patient has health insurance, including coverage under Medicare, Medicaid, or a health insurance plan issued by a health insurer, as defined in section 9402 of this title, and the patient provides the hospital with proof of health insurance not later than 90 days after the patient's discharge from the hospital. So in this instance, we're looking for if the patient has Medicare, Medicaid, or is covered by health insurance, then the hospital would not be able to file a lien on their recovery as part of the lawsuit. If the person was uninsured, for example, then the hospital would be able to pursue a lien. Having said that, it's still contingent upon the patient providing the hospital with proof of insurance. So if the patient doesn't provide the hospital with proof of insurance, then the hospital could still pursue a lien, even if the person has Medicaid, Medicare, or health insurance plan. An exception to that in subdivision 2 is that a hospital may file a lien pursuant to subsection A for any amount owed to the hospital for the patient's deductible or co-insurance, or both, under the health insurance plan for the medical services or other services furnished by the hospital. And then the hospital would have to file a notice of lien at least 120 days after billing the patient's health insurance plan for the amount owed.
So they couldn't come back 10 years later.
Correct. Subdivision 3 says that the patient's health insurance plan shall not deny payment for the services furnished by the hospital to the patient on the basis that a property and casualty insurance carrier is responsible for the patient's injuries unless such denial is required or expressly permitted by state or federal law. So in these circumstances, for example, the injured person has auto insurance and as part of auto insurance coverage, they have coverage for a portion of medical expenses related to the crash. So this says that the patient's health insurance plan can't deny payment for services furnished by the hospital just because that person may be able to receive coverage for those medical services through their auto insurance plan. With the exception that if that denial could be required or expressly permitted by state or federal law. And here we get into some of those circumstances of payer of last resort, of Medicaid being the payer of last resort, in which case the Medicaid could deny coverage by saying you need to go to the auto insurance because we're the payer of last resort.
Right, which we just talked about earlier.
So, the question on this list.
Yeah, so if the individual's out of state
Yeah.
and they have, and going back to the auto accident, they're uninsured motors, only covers so much. I mean, does that matter in this case?
Well, this is specific to services provided by a hospital in Vermont.
Okay.
So, so in this example, if the person out of state was in Vermont and got in a crash and had, say, not great auto insurance coverage that came nowhere near to covering the costs, that I would say does not really affect what this process looks like. It might affect the monetary outcome
Right.
for who is able to receive what. How much. So subsection C. So now, if you recall, the original language says, the current language in statute says that a hospital's lien is subordinate to attorney's fees. So this also, subsection C also concerns attorney's fees. A hospital that recovers under this chapter shall be responsible for a pro rata share of the legal and administrative expenses incurred in obtaining the judgment, settlement, or compromise. So now in this instance, so in your original current law scenario, you have a set amount of money that the patient is getting as a recovery from the lawsuit. You subtract the attorney's fees from that recovery amount, and then the hospital would be able to file a lien for the portion that would cover their services, or to the extent they could, given the money that is remaining. In this instance, the hospital would be responsible for paying a portion of the, essentially a portion of the attorney's fees. So it changes the amount of money that a hospital would be able to receive through the lien process compared to current statute. And then in subdivision 2 in subsection C, says in no event shall the hospital lien exceed 1/3 of the net judgment, settlement, or compromise received by the injured patient. So this would place a cap on, there is technically currently a cap in current law, because there is that $500 or the 1/3 where the patient would always still be able to receive. The hospital lien could not attach to that last $500 or 1/3, whichever is less. Now this would place the cap at 1/3, 33.33, 1/3 of the net judgment. And then in addition, the hospital will also have to pay its pro rata share of the attorney's fees. This is a lot of math that I won't get into because I'm not great at math. There were some good examples that were all discussed in Senate Judiciary. So, and the act would take effect on January 1st, 2024. One thing I wanted to note about the language in subdivision 3. So much of this language was a collaborative effort on how to word all of this. That was reviewed a lot, but it was not within a very long time frame. So I would, if the committee is interested in moving this language into an amendment for H206, I would ask to amend subdivision 3 slightly, because it currently says on the basis that a property and casualty insurance carrier is responsible for the patient's injuries. And it's really not that they're responsible for the patient's injuries, it's that the cost of the patient's care may be covered by a property and casualty insurer. It makes it sound like the insurer is responsible for the patient's injuries, which is not the case. It was an accident.
Okay, and I'm looking at the 2 principal interested, 3 interested parties here, 4 interested parties. Yeah, and you're all shaking your head in the right direction. Good, okay, so we'll put that in as a proposal amendment. Yeah, okay. Go ahead.
Oh, sorry.
Already has a question.
I have a question for each of you. First of all, is this bill, I thought it was in rules right now.
It may well be in rules, and we're going to add it into 206 as an S bill. It probably would be better to add it here. It does fall within the jurisdiction of our committee. And so judiciary has taken a lot of time and effort with folks to come together on the language. And we're gonna put it.
I see.
If we
Okay, I missed
yeah.
that. I missed
Yeah.
that part of the plan. Sorry about it. And then my question for you, I think I know the answer to this, but just to make sure I understand it. If a patient is insured, their insurance would pay the hospital for the cost of their care up to the limits of their insurance. And then the lien would only be on whatever is left, the co-payment or the person's share of it, or could be.
So scroll back up here. So the statute does not require the hospital to go to the insurer or Medicaid or Medicare. Or logically, it would make sense for them to, because this is removing their ability to file a hospital lien for their full amount.
Yeah.
This still allows a hospital to file a lien for any amount owed to the hospital for the patient's deductible or co-insurance, right, which is the patient's cost share responsibility.
Right.
So they could pursue the insurance for the insurer's piece, and then they could file a lien for that remainder that is the patient's cost share, if for some reason they do not believe they're going to receive it from the patient, or they have not received it from the patient.
Okay, so is a lien just assurance of payment for the hospital and or the attorney? If the person pays the co-payment and pays their attorney, there's no need for a lien, right? A lien isn't an automatic thing.
Correct.
Right.
It is
Okay.
discretionary.
It's discretionary. And then for people who don't have insurance, what if the cost of their bill to the hospital exceeds the amount of the settlement?
Then they cannot file a lien for more than what?
More than the 33.
More than the recovery, and in this case, yeah, and more than the 30%.
So if the settlement is $1,000, the most the hospital could get is $333.33.
Minus their pro rata share of the attorney's fees.
Minus, okay. Okay, so I'm looking at who gets paid first. Okay, I think I understand it.
So here's a good thing, Senator. Judiciary did us a service by doing this bill. It actually could have landed in here, but now we're getting the benefit of all the work.
Yeah, I mean, if it had landed in here, I would have wanted all the math,
I know.
but I'm gonna trust that they did it.
Did you have another question?
No, I just wanted to talk it through to make sure I was understanding it. And it sounds, I also am just sort of a little bit of concern that uninsured people are, again, getting the raw end of the deal, but I think with the limits on the amount that can be taken, then they would still end up ahead.
I would compare it to what is the current status of the law, which is that an uninsured person, if they have very high medical costs and attorney's fees, they would only have $500.
Yeah, but now they could potentially
They
get
could
more.
potentially have more because it's capping the hospital lien to 1/3, and it's requiring the hospitals to pay a pro rata share of the attorney's fees, which otherwise would have come from the patient's
Right, okay,
recovery.
that makes sense. All right, thank you. I'm good.
Senator Reese.
If I could, I'm gonna take you back to the beginning. What problem are we solving here?
That is a question that the witnesses can probably answer better than I can.
So why don't we do this? That's a very good question. And I know that we've got 4 witnesses in here who have been working hard on this bill. But just stay where you are and we'll just have a conversation to understand how the agreement was made. We'll start out with what's the problem that we're trying to solve and who would like to solve it.
Sure. David Mickenberg here on behalf of the Vermont Association for Justice. The problem, senators, is that under the current statute, which I think was came about at a time, I don't know how many years old it is, but it's many decades old. Came about at a time when we had about 10% of our population insured. Now we have 97% of our population currently with health insurance. And understandably, when there was only 10% of the population and 90% is uninsured, the hospitals were trying to sort of figure out a way to recover the costs of the medical care they provided. But that statute translated to the current situation means that that it could be that somebody who is, and has happened in Vermont, somebody who's in a car accident doesn't have their insurance charged, meaning that they're not paying down their deductibles and getting the benefit of the negotiated insurance that their employer, they have negotiated for, including the negotiated rates that they've negotiated with the hospital. And instead, a hospital could and has put a lien on the recovery of a lawsuit in which they would get more money through, the hospital would get more money through that than just charging the insurance. So as an injured Vermonter, you're both not getting the benefit of the insurance that you either paid for or your employer paid for, and you're getting less of the recovery, in some cases, very little. I mean, under the current statute, if the hospital spent, $10,000 on your treatment, and the recovery was $10,000 in the lawsuit, which you went out and got an attorney and spent time and effort on, the hospital could take $9,500 and the claim would be left with $500. There's attorney fees, things like that to complicate, just to make it simple. But after the attorney's fees. So I also am not good at math. So, but basically, it's the essence of the problem is that it's possible and does happen here and all over the country, actually, where somebody's not getting the benefit of their insurance because they're just having a lien filed on the car accident or the third party claim, and they're not able to recover as much as they should to compensate them for their injuries. So this, I have to say, and I just want to say, this was, we spent, well, Rebecca wasn't there, but Sarah Teachout was, Blue Cross, we spent a lot of time and a lot of effort. And I feel, there's a lot of compromise in this, and I feel really supportive of it and appreciative of you taking it up and of the work that has gone into it. So does that kind of define the problem?
It helps. Thanks.
Yeah.
So it's an old statute. It doesn't reflect current process or procedures that should be in place to ensure, one, that a patient is getting full coverage from the insurance that they do have, and two, if that any lien that's placed on them is equivalent with what they owe versus what they being charged.
Oh, no, I was just gonna add that Senator Bihovsky told me that it's 100 years old.
It's what?
Yeah, it's 100 years old. The
Is that how
statute.
old this statute is? How old is it?
Our online statute says 1963.
Oh, okay.
1963?
It's 75.
75 years old.
53 or 63?
63.
63. So, no, it's only 6. So the math is.
It's 60.
The math is 60 years. I know, if we take a third of that, it's only 20 years.
There you go.
Plus or minus 4.
Okay, so a 6-year-old, yeah, we've seen a couple of those recently. We had one from was it 59 or 69 the other day? Yeah,
We were just in Senate Economic Development working on a policy from 1959. So.
yeah, that's the one. Oh, yeah, okay. All right, so so Mike, yes, please.
Just to say out loud, healthcare advocate, we're a part of this little working group and
Good.
support the compromise. I think it is a step forward for Vermont consumers.
I'm Devin Green, Vermont Association of Hospitals and Health Systems. I agree. I think this does modernize things. I think it strikes a balance because hospitals do have to accept everyone who comes through their emergency departments. So it strikes a balance between making sure that someone gets their fair share of their judgment, but also making sure that we don't have to pass on free care to other commercial regulators.
Yeah, I know.
Rebecca Covance with Constitutional Vermont. We pursued this bill because we should have faith that when someone has insurance, that their insurance steps in for them. And they should not have to be put in the middle of, hospitals and auto insurance claims. That's why you have insurance to protect you in this instance. So thank you for taking that.
Good, thank you all. I know that you worked really hard. I know that. I've been hearing about it along the way. Great to see resolution. So, committee, this is the bill, and we'll take a hiatus. We won't, say yes or no, we're gonna do it. But it sounds like something that would fit onto the SH 206 amendment. We'll go forward with it. That now that there's agreement in the room, so it does help once the bill begins to get across the way. And then the language change that you found, we should probably look at the next time we look at this. I think we have it on the agenda for next week.
Would you mind if I run my proposed language by?
I would love it if you would run it by them, so we don't, yeah, great. Okay, terrific. So, in keeping with our word of the day, we are going to take a 5-minute break.
What was the word of the day?
Alacrity.